Good afternoon, everybody. First, I would like to thank the organizer to invite a laboratory guy to talk to you. Second, I like to thank the previous speakers to put me after lunch, because that's my preferred spot. My job is to keep you awake in the next 30 minutes. Just kidding. I will talk about, with two epi-slides and then move on to Toolbox 1 and 2, growth detection, identification of NTM, then susceptibility testing, and two surveys, one general microbiology laboratory and one public health laboratory, because one objective today is a laboratory is not a laboratory. Like we learned from our patient panel, a doctor is not a doctor. There are differences, and hopefully you will recognize that there are differences. I have no financial disclosures. The first epi-slide, we may have seen it again. What are we seeing in the laboratory? This is from 4 managed care organizations, primarily avium complex, and this is a little bit an older taxonomic name, Chelone abscessus. Today, the Chelone is separate from abscessus, and the abscessus is divided into 3 subspecies, so actually these are 4 different taxa, then Fortuitum kansasii, Simie, and Xenopi. The other important thing, since we're also talking about CF, a slide about NTM and CF. This is a study from France. You can see in the beginning of life in CF patient, the abscessus dominates over avium, and as the CF patient ages, then the MAC ultimately takes over. So this is a natural course. It's almost like a children's disease, certain bacteria you have at certain ages. Now moving on to the toolbox. And for many of you, probably the toolbox is a box, meaning a black box. The sputum comes, and now you would like to know what we actually do. And we heard about Staphylococcus, we heard about Pseudomonas. So we actually need to kill these more rapidly growing organisms in order to grow the slower mycobacteria. When we treat, as we call them, or decontaminate, it's with sodium hydroxide, and if there is a history of Pseudomonas, we need to double down with oxalic acid. So just remember, in order to have a pure culture, we need to be very harsh to the sputum. Then the smear microscopy, acid-fast bacilli, AFB stands for. We heard already that TB was in a differential diagnosis from one patient, but we need clearly to differentiate. NTM has nothing, and I repeat, nothing to do with tuberculosis. Just the staining characteristic doesn't mean that we always need to think of TB and have that stigma associated as well. Then we have solid medium, we have broth medium, and then some molecular assays. And since globally TB is a little bit more important than NTM, unfortunately, molecular assays were developed towards TB, but there is hope that also the NTM will take advantage of these latest development. And of course, when you assess your laboratory, make sure the laboratory doesn't work only 5 days a week. Now the culture becomes positive. Now we do the same thing all over again, or if you are a reference laboratory, then we don't get the raw sputum, we get the culture, and of course, Similar to bacillus, where we need to rule out bacillus and traces, we also need to rule out, since we don't know if the patient is a suspect for TB or for NTM, we certainly need to rule out TB. Again, that's why we have these molecular tools. But there is also now, and I will talk about, one which gives us, in terms of identification and drug resistance, some rapid results within 24 hours. So that's very good. Then the identification, there is various assays in the past, nucleic acid probes from the 80s, Lyme probes, I would say, from 2000 on, MALDI maybe just the last 5 years, and then, of course, Sanger sequencing, when you really deal and try to identify all various species. Since we have a pure culture, we do then antimicrobial susceptibilities with MICs, respectively, even combination MICs. Now, moving on to growth detection, this is what we are looking for when we have no clue if we need to look for TB or for non-tuberculous mycobacteria. As I said, we need to decontaminate the sputum in order to have a pure, ultimately a pure culture. In the picture, you see 2 colonies from Mycobacterium tuberculosis, and here on an agar plate, you see Mycobacterium abscessus. That's the older term. Now we would say Mycobacterium abscessus, subspecies abscessus. But we also need to, and then this is a new addition. This is not FDA approved. It's not even commercially available, but in Europe it's already in use. This actually is a study carried out last year at Chapel Hill. So another solid medium, a selective medium. They tested 212 sputum samples from CF patients and compared the regular CF medium Burkholderia selective agar versus this newer medium versus 2 traditional TB medium, Midget, the broth medium, and Löwenstein-Jensen. But instead of decontaminating, they went directly with the sputum onto the agar, so no pre-treatment. And then for the TB media, of course, the double decontamination, the plates were incubated at 28 days, and the other medium, since TB needs to be ruled out, 56 days. So the results, I think, are pretty stunning. So with these 4 different media, they had a total of 51 isolates and top abscessus subspecies, abscessus 29, and the Burkholderia bacteriologic medium yielded 7. The double media from Mycobacteria AFB 18, and this new medium 28. So that's darn good. Chelone, similar immunogenome. Then MAC usually takes a little bit longer, but also, as you see, 7 total, but 5 with this new medium. And so overall, the new medium picked up 47 out of 51, and the conventional microbiology medium with the Burkholderia selective agar, 11, and the AFB combination, which some laboratories do, a broth and an LJ medium, just 24. So it is a difference. Again, it's not FDA approved, it's not yet commercially available, but there is at least some light at the end of the tunnel. In terms of identification, I showed you before the rough M. abscessus colonies, And you can see them again, so to speak. These two large colonies would be the rough abscesses. And then the smooth variant, you see all the other ones. And you may actually not see underneath translucent, all over the agar plate, like a milk glass, is an avium. And we heard already from Oregon that avium and abscesses sometimes are together. And if a laboratory looks only for the first appearance of colonies, then they go after the rapidly growing mycobacteria and will not detect the slower growing mycobacterium like avium. So it's important to keep going with the incubation to give other mycobacterium also a chance. Now you heard more than 180 species. As of yesterday, we actually differentiate 196. So soon we will hit 200. So there are 4 distinctive diseases. 1, TB. 2nd, leprosy. 3rd, Buruli ulcer, the skin disease from the tropics. And 4th, that's why we are here, all the NTM. So the vast majority of these taxa are NTM. So it's important to know which one we are dealing with and not just complex or groups or whatever. As I mentioned, the MALDI-TOF is a mass spec. The instrument costs about $250,000, so not every laboratory can afford it, but it's probably the latest thing to have in a modern laboratory. When you have the instrument, that's the expense. The consumables for normal bacteria is probably $1, an identification, and AFB, since you know we are special, $2. But that's still cheap, but you need to first to have your instrument. But even with a new instrument, there are limitations. This is a study from Mayo Clinic. They were able, in their evaluation, to determine 88% of all the mycobacterium isolates to the species level. As I said, we shouldn't be happy enough when we lump things together. We really need to know which species, or in abscesses, which subspecies. 90% of nocardia, and then 51% of other anaerobic actinomycetes. So with other words, we can use the MALDI very good as a screening tool and may need to follow up still with sequencing, but the MALDI you can do in a matter of a few hours once you have a culture. For the rapid growers, you have also the ERM41 gene, which allows you to differentiate 2 subspecies from the 3rd one. So you have the Masseliense versus the abscesses and the Bolladii. And in this particular case, it's also associated to a high degree with induced macrolide resistance. But it's not 100% correlation, as we will see later. So the Masseliense has a truncated ERM gene, so it's actually lighter compared to the others. And so you see the green arrow, that's why the Masseliense on the gel travels further because of the lower molecular weight compared to the red arrow, where we have abscesses and the Bolladii with a intact ERM gene. We also heard that 11 states have an NTM as a reportable disease. This is just a map of the United States, and all the green states have one sort or another the requirements for the laboratory to report NTM, and success is made, progress is made in terms that the Council of State and Territorial Epidemiologists, now we heard it already from Kevin, that extrapulmonary NTM is a little bit easier to define than the pulmonary, and so they came up with a case definition for extrapulmonary. So probably within a year, maybe 2 years, we will have nationwide, as a starting point, the extrapulmonary NTM, and hopefully then subsequently we will have more states who will require the pulmonary NTM as a reportable entity as well. Just for your file, I visit all the websites, so you can read this then when you access the slides after the conference. The antimicrobial susceptibility, here we have standards, CLSI standards, which are nationally agreed upon. Currently they are in revision, and they separate out again, number one, M. tuberculosis, then avium, then Kansasii, Marinum, some other slowly growing NTM, and then the rapidly growing mycobacteria. As I said, they are currently under in revision, but I give you two highlights. We are here in an area where we don't have always clinical trials where we can correlate laboratory results with the actual outcome. And so this is really where we have the most information. Some laboratories actually will test more than what is recommended in these guidelines. And the first-line drug for MAC, no surprise, the macrolide and aminoglycoside here, amikacin, and if any of them cannot be used, then one should shift to the second-line drugs, moxil, linezolid, clofazimine, and so on. But again, as a reference laboratory, they may do this all at once and not do tiered testing because of the time involved. For the rapidly growing, there is not much change in the first-line drugs. We have certainly more. But then in the second-line drugs category, it will be recommended, as I said, this is still draft, it will be recommended that the laboratory reports just the MIC, and then the doctor ultimately comes up with the interpretation. Again, since there are no clinical trials correlating laboratory results with patient outcomes. So this is just our menu card at the National Jewish Health. We have a 15-drug MIC panel with some combination. We have a 20-drug panel, and then for the slowing growing NTM, meaning MAC, the 10-drug MICs together with RIF ethambutol combo. Another assay which is not FDA approved and for research use only, it's commercially available, it comes from Germany, is actually a pretty neat test that with this line probe, it's like a filter paper, and there are several probes on it, and the first part, as you can see, we have some controls, and then SP1 through SP10. This will allow us a combination of these various probes when they come up to determine the identification, and there are only the avium complex with avium intracellare chimera on it, and then the chelone, and then abscesses and the three subspecies. And then the bottom half of this paper strip, there are additional probes which give us three resistance markers. One for the ERM41, the delayed or induced macrolide resistance. Then RRL, the overall macrolide resistance and RRS locus as the aminoglycoside marker. So we tested this in our laboratory, and we compared it to the real gold standard, meaning whole genome sequencing. I don't have time to go into that technology, but that's the latest when we go for the reference methodology. So in this particular case, we tested 163 M. abscessus, and as you can see, the distribution, subspecies abscessus 122, 36 Masseliense, which has this truncated gene, so actually responds better to macrolide resistance, and then Bolladii, which is usually very rare. We had only 5. But in terms of sensitivity and in terms of specificity, it really matched what we came up with whole genome sequencing as the reference method. Now, as I said on the second part, we have the drug resistance marker, the RRS for aminoglycoside, and we tested here 151 compared again with whole genome sequencing. Pretty good. We had only 14 who actually were resistant, fortunately, and so that is then 9%. With the macrolide, the general macrolide resistance, we had only 3 of them being resistant, and then with we tested only the abscessus, subspecies abscessus, and abscessus subspecies Bolladii, but here also you can see a very good correlation. The interesting situation there is that in our collection of abscessus abscessus, 14% actually had an intact gene, so actually would be also similar to the Masseliense, susceptible to a macrolide. So we should not assume that all abscessus abscessus are at some point may trigger the induced or acquired drug resistance. Now, how does that look in a real batch? All these various columns are these line probes, and first we identify with the blue arrow the various band patterns. In this particular case, 4, 5, 6, and 9, and 10. That means it's abscessus, subspecies abscessus. And then below, just with the macrolide, the ERM41, you can see that there is the red arrow where the actual locus is for the mutatant marker, and between something is missing. This would be the wild type, meaning susceptible. So in this particular case, this abscessus abscessus is really macrolide resistant. Now to my last part of my presentation, the 2 survey. One is done by the Association of Public Health Laboratories in 2010. So everybody who does anything, meaning laboratories, who does anything AFB were invited, 1,400, and 45% ultimately responded. And so you recognize 80% are hospital-based, 9% are state public health, 4% commercial, and so on. So what is the result? Green is NTM, and red is TB. So you recognize the culture positivity between 1 and 10%, that there are more laboratories in the United States which answered the survey which have more NTM positivity than TB. So that tells you whenever we have a new patient with AFB and we don't know yet what it is, the likelihood is it's an NTM and not a TB. And then same, even the ones which have more than 10% of culture positivity, then we have 40 labs with NTM and only 22 labs with TB. But we also need to recognize that not every laboratory goes the extra mile and does the full identification. So we have all do TB complex more or less. Then you have some NTM, then most NTM and all NTM. So you see the number of laboratories actually get smaller and smaller. Now last fall we did a survey among the 50 state public health laboratories, because oftentimes if the patient really is primarily in the differential diagnosis a TB suspect, the sample may be sent to the state lab. They do it most part for free, so there is an incentive, but here again it's important to know what are they doing when it's not TB. So first, the molecular, we have a rapid test for molecular TB detection. And so 37 out of these 50, they do only the TB NAT. And when that is negative, then it's negative. No follow-up. And then, but already 11 of the state laboratories, representing 17% of the US population, have a TB and a MAC molecular detection. So there, at least you have at the same time a negative TB, which is okay, but obviously the patient is sick, then you have a chance for a positive MAC. So I think this will increase these molecular direct detection with NTM as we recognize the awareness and the prevalence of NTM is daily increasing. The NTM workup, in-house all, you see only about 50%, and some 40% of the state lab do in-house and may or may not send it out to another reference laboratory, so it may stop there. What are they using for the identification? MALDI-TOF, as I said, for many state laboratories, it's quite an expense, $250,000 for an instrument. And in their TB laboratory, and we know TB is going down, so why would government spend money on TB? But still, almost 40% of the state labs, they have access to a MALDI, and another 40% do the sequencing, where they actually then can differentiate and identify almost 200 NTM species. So that's actually good news, but as you can see, one laboratory already uses whole genome sequencing in the diagnostic realm to identify the NTM. And lastly, the only 6 of these state laboratories are subspeciating the abscesses. And we know the Cystic Fibrosis Foundation recommends that it's not good enough to have M. abscessus group or whatever you call that. We really need to have the subspecies. So here again, at least 6 are doing this. But as I showed with this non-FDA approved, commercially available from outside of the United States, we actually within 1 day, once you have a positive culture, within 1 day, you have not only the important drug resistance marker, but you also have the identification. And when it's not part of abscessus, cheloni, or avium, then you resort back to sequencing. Then my second last slide is National Jewish, Chuck Daly and myself. We are maintaining a bi-monthly newsletter, which is called NTM TB Insights. If you need more information, then just Google. We have about 1,000 subscribers, so we are very proud. We launched that 3 years ago. And guess what? 30% are patients and family members. We love that. And then, since we have a blue sky here in San Diego, I just want to remind you we have also a blue sky in Colorado. Thank you so much.